I would be talking, this is the brief outline of my lecture, starting with the definition of COPD, sign and symptoms, differential diagnosis, how to investigate, what is the management, a little bit talk on the exhibition. Excuse me, आपकी आवाज आ रही है, Ravi, please. Respiratory failure, its definition, types, mechanisms, and pathophysiology. COPD. Excuse me, Ravi. Excuse me, Ravi. IT department, please. Hello. Hello.
Hello, sir.
Hello, Ravi. ये प्लीज आप ये इसकी विंडोज तो रिमूव करें ताकि मैं लेक्चर सही तरह से दे सकूं। ये सारा वो ऑब्सक्योर हो रही है। आपकी DUH है तो तीन विंडोज इसमें खुली हुई हैं।
सर आपकी स्क्रीन
और आपके जी मेरी स्क्रीन पे आपकी खुली हुई DUHS और ये आ रही है, प्लीज इसको हटाइए ताकि ऊपर भी आ रहा है 3 people entered और वो मेरी स्लाइड्स को सारा ऑब्सक्योर कर रहे हैं।
सर तो उसे ड्रैग एंड ड्रॉप करके आप साइड में कर दीजिए।
मैंने तो किया लेकिन ये कैसे होगा, ये बाकी तो वो नहीं हो रहा, ड्रैग साइड पे ही है लेकिन वो इसको
वहाँ से आप फरीद साहब को आवाज लगा दे, वो कर दें क्योंकि वो आपकी साइड की स्क्रीन है सर। यहाँ से
फरीद साहब तो यहाँ पे नहीं है इस वक्त, तो ये मैं पढ़ नहीं सकता, स्लाइड नहीं पढ़ सकता, ये सारी वो छुप रही है यहाँ से, मेरी स्लाइड छुप रही है, हटा दें थोड़ा स्लो।
उस आप कैंसिल या मिनिमाइज कर दे सर।
या इसके ये हटाना है, ये और ये हटा दीजिए साइड की ये चीजें जो मेरी स्लाइड छुप रही है।
शायद वो कैंसिल कर दो या मिनिमाइज कर दो।
यहाँ पे क्या रहा है, ये भी इसको वो आपस में बात कर रहे हैं, वो भी मुझे आ रही है। रवि जो है इस पे क्लिक करोगे तो नहीं आएगा, हट नहीं आएगा।
सर इनको माइक दीजिएगा
जी,
इनको
इनको आपसे बात करना चाह रहे हैं, ये लीजिए।
शायद 2 स्क्रीन होगी, एक पार्टिसिपेंट्स की, एक चैट की, ठीक है। हाँ, तो वो उन दोनों स्क्रीन पे कैंसिल या मिनिमाइज्ड होगा, वो कर दो या ड्रैग एंड ड्रॉप कर दो।
ये दोनों जहाँ पे स्क्रीन नजर आ रही है ना,
हाँ
सेट कर दो तो मेरी इसको मिनिमाइज करो, ये वाला उसमें भी मेरी भी चली जाएगी। नहीं
जो पूरी स्क्रीन जा रही है मिनिमाइज में ना।
अरे बात सुनो, वो ऊपर सबसे टॉप पे लिखा होगा व्यू ऑप्शंस, उस पे जा, हाँ उसमें देख लो फुल स्क्रीन या एग्जिट फुल स्क्रीन, वो कर दो।
जो 103 वाली किसकी आ रही है?
अरे वैसे सर को बोलो हमारी तरफ एकदम ओके है, ठीक है, हमें सही
यहाँ पे तो आ रहा है, यहाँ पे तो आ रहा है ना, इसको मिनिमाइज भी नहीं हो रही ना यार। ये
फरीद भाई को बोल के करवा दो।
नहीं हो रही वाला
फिर बोले करवाता हूँ साइड में इसको मैं, ठीक है?
हाँ करवा दो।
ओके,
अभी रुक जाए, लेक्चर रुका हुआ
एक से हो गया।
शुरू करें, उससे बोले हेलो हेलो।
जी सर
हाँ जी, लेट्स स्टार्ट, शुरू से करें।
नहीं सर, जहाँ से रुका था वहीं से।
हाँ यहीं से चलें, स्टार्ट करें। ये मेरी चल नहीं रही, स्लाइड रुक गई है, स्लाइडें रुक गई हैं। हेलो
जी सर।
नहीं वो तो एक सेकंड, स्लाइडें रुक गई हैं, ये रहा शायद यही वाली ना। हाँ यही वाली, एक सेकंड। एक मिनट
प्रधान
रुकिएगा। हाँ, आप चल रहे, एक सेकेंड ऊपर आगे कर लें इसको जी। ओके,
जी सर।
so logistic issues, but we have come to the lecture now. Okay, so definition of COPD. COPD is a common, preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. Regarding diagnosis of COPD, the same thing, we start with what are the common symptoms. The symptoms of COPD are three main symptoms. One is shortness of breath, second, chronic cough, third is the sputum production. Then we have to evaluate that persons which are having these symptoms, is there any risk factor for person to have COPD? And what are those risk factors? They are host factors, tobacco. Tobacco is the main etiological reason or cause for causing COPD. In roughly about 90 to 95% of the cases is due to smoking. Occupational hazards. Yes, that is very important. Biomass exposure, indoor and outdoor pollution. There are other risk factors also which can contribute in a person or predispose a person to have COPD. But all of this, the symptoms, even on examination, they are signed. I'll go into the details of what are the main symptoms. So dyspnea, we talked about dyspnea, shortness of breath. So the characteristic of dyspnea is generally that this is progressive over time. This is not an acute dyspnea in general. Yes, acute may happen in a person with COPD, but that will be an acute reason for this. For example, pneumothorax or mucus plugging or something like that. But in this thing, there is a progression over time, and characteristically, the dyspnea is worse with exercise. And third is another very important characteristic, it is persistent. That means it's present in day, night, days, weeks, months. It can be more in certain seasons, but it's present all the year round, more or less. So that is the characteristic. Chronic cough, this another main symptom, that may be intermittent, may be productive, may not be productive, may be associated with wheeze, or generally it is associated with wheeze. The chronic sputum production is also one of the hallmark for COPDs. Risk factors, we have already talked: tobacco smoke, home cooking, heating fuels, that is biomass exposure, and these are also very important to ask in the history. Regarding cough, because cough is such a very important symptom, but it has got numerous causes, numerous reasons. Those reasons we can divide them into easiness, inside the thorax or outside the thorax. Inside the thorax, the common causes of chronic cough. See, chronic cough is the cough which is present for at least 4 to 6 weeks. So among this entity, the chronic cough, the causes are asthma, lung cancer, tuberculosis, bronchiectasis, left heart failure, interstitial lung disease, cystic fibrosis, like this. And in extrathoracic, that means outside central cyanosis. It's not common, but it's one of the signs for COPD. Pulmonary hyperinflation, as the name suggests, pulmonary lungs, hyperinflation, the lungs bade ho gaye hain, the lungs have increased in their size. This is hyperinflation in simple words. So how does it appear in the examination? What happens? You see barrel-shaped chest. And what is a barrel-shaped chest? Barrel-shaped chest is when the anterior posterior diameter of the thorax is more or equal to the transverse diameter of the thorax. So it looks like a barrel. simple words. So when that happens, the ribs which are at an angle, normally they become more horizontal. So relatively horizontal ribs, and the abdomen protrudes up. So there are some signs which can suggest if a person is having pulmonary hyperinflation. Another is paradoxical indrawing of the lower rib cage on inspiration. When a person inspires, the lower ribs, they go out. But in this case, in COPD, there is paradoxical indrawing of the lower ribs. Lastly, the Zifi-sternal angle becomes wide also. Resting rate, they are usually tachypneic, maybe or may not, but generally. So respiratory rate is often increased in a person with COPD. There is another thing we call it pursed lip breathing, where they purse their lips, and this way they increase the intra-airway pressures that helps to keep the airways in expiration to remain open so that the air can come out of the lungs. That is how the pursed lip breathing helps in a COPD patients. There is resting muscle activation. They may have Apart from this, COPD is distinctive in having, is not limited to having airway disease. It is an airway disease, but it has systemic features also. And that is one of the features are cachexia, loss of fat-free mass, skeletal muscle wasting, apoptosis, disuse atrophy. They become short of breath, they don't walk, the muscle becomes wasted, that leads to further decrease in their exercise capacity. So it's a vicious cycle, positive vicious cycle leading to crippling of the individual in general. Osteoporosis, depression, anemia, which is generally normocytic, normochromic, and obviously increased risk of cardiovascular disease as well. Now, these diagrams too, one on my left-hand side, is blue bloaters written over here. So you can see there is no obvious increased work of breathing. He's sitting there and the lips are blue, cyanotic, and their legs are swollen. He got peripheral edema. This is a blue bloater. Another appearance is the pink puffer. Here you can see the person looks to be in respiratory distress using the accessory muscles of the neck. He looks to be cachectic. The other one looked to be more on the obese side. He looks to be more on the wasted side. There is pursed lip breathing. There are retractions, and he is keeping his both hands in front of it and using, in this way, it helps in using the accessory muscles of respiration. So it's increased work of breathing. So this pink puffer is generally associated with emphysema. The blue bloater is generally associated with chronic bronchitis. Both are the integral components of COPD. Both come under the umbrella of the bigger term, which is known as COPD. Not diagnose COPD alone unless we confirm it with spirometry. So spirometry is essential. And in the spirometry, the diagnostic criteria says you have to check the FEV1 FVC ratio. If you can see a diagram on my right-hand side, see in the lower one, there's a box, FEV1 1.8 liters, FVC is 3.2, and the ratio. This ratio is very important. FE1 over FVC of 0.56. And it's written over here that it is obstructive. So any ratio of FEV1 is the forced expiratory volume in the first second divided by FVC. FVC is forced vital capacity. So if this ratio is less than 0.7, or you multiply by 100, 70%, so it has to be obstructive, clear cut. The obstruction is present. And this you can see here. So in the diagnostic criteria of COPD, in order to confirm, we have to check the FEV1 FVC ratio, which should be less than 70 in the post bronchodilator study. So PFT is done in general stages. First stage is the baseline spirometry, also known as pre-bronchodilator. And after completing it, we give short-acting beta-2 agonists such as salbutamol in the form of an inhaler or a nebulizer, and you give it, and after 15 minutes at least, we repeat the same study again. This is known as post-bronchodilator study. So I'm talking about the ratio in this, the afterwards, the post-bronchodilator, the ratio should be less than 70. Then it is confirms that person is having COPD with the signs and symptoms. Flow volume curve. This week, the volume is there on the, you see, on the x-axis, and flow is on the y-axis. And you can see a very scooped, the above the line is the expiratory limb, below the line is the inspiratory limb. So inspiratory limb seems to be okay, but the expiratory limb is generally scooped, concave. So this is very classical for obstructive airway disease. Here you see the ratio. If you go to the FE1 FVC, it's written over here in the diagram. So the baseline was just 26 here. Page is just 26. This is the ratio FE1 FVC, and the ratio is just 26 baseline. And then the post bronchodilator. Here I was telling you we have to check the post bronchodilator, which is also 28, from 26 to 28, but still it's less than 70. So if it's less airway disease. Second thing, look at the reversibility. So reversibility is checked by FE1, not by FVC, or not by the FE1 FVC ratio. So in general with FEV1, the FE1 was low, 0.93. The normal range was greater than 2.34. So 0.9 is obviously less than this one. So, but in the post bronchodilator, it has increased to some extent, but not the significant extent. And the change is only 9%. So what is the significant reversibility? When there is increase of at least 200 ml from the baseline. So 0.93 may you add 200 ml plus there is a 12% increase change. Here is only 9%. Then we call there is significant reversibility present. Okay. Now based on this, now we have to classify also. It helps us in which gold stage it is. Gold is the criteria used to assess the gold are the guidelines, global initiative for lung diseases. So that is generally used as a main guidelines for the management and diagnosis and management of COPD. So there are 4 stages here: 1, 2, 3, and 4. Where's my? All right. So in gold stage 1, it's based. All of this grading is based on FEV1. So in the FE1, if it's more than 80% of the predicted, it is in gold 1. If it's in gold 2, it's between 50 and 80 of the predicted. Gold 3 is between 30 to 50, which is severe. Gold 4 is the very severe, which is less than 30% predicted. Please note that although the FE1 normal range is from 8 normal. Yes, the FE1 is normal, but the ratio, but the ratio here is not normal. So we have already taken those patients who have the ratio is less than 70. When the ratio is less than 70, there is documentation of airflow limitation. And then you can categorize. So even with the FE1 of 80% or more, but the ratio is less, so it's not normal. Okay, next. MRC dyspnea scale. I don't want to go into detail, but I'll just go through briefly. It's important. It's a simple tool we use in daily practice. The MRC is the modified Medical Research Council grade from 0, 1, 2, 3, and 4. 0 is I only get breathless with strenuous exercise, and the last grade is I'm too breathless to leave the house, or I'm breathless when dressing or undressing. Another assessment tool is CAT. You don't need to know this, it just is for mentioning it. CAT is also used in determining the severity. Now, based on all these things, so if you can here see, that's after this parametrically confirmed diagnosis. Where's my right? Go for airflow limitation. Airflow limitation is present when the FEV1 over FVC ratio is less than 70%. Okay, so this we have discussed, and then we combine with this knowledge with we make a grade here, see here, symptoms, and we have the history of exacerbation. Based on these, we divide them into A, B, C, and D. This is the classification used for complete severity assessment for COPD. Spirometry is just a component of assessing it, which is here, which I've already discussed before, gold stage 1, 2, 3, and 4. With the exacerbation history. If there is a previous exacerbation history, this is on the y-axis. Which thing is on the y-axis? Exacerbation history. Which thing is on the x-axis? These symptoms. Symptoms, how to assess symptoms? By two things. Either you use the MRC scale, which I have already just mentioned very briefly, and other is the CAT score. So whatever it is, when it is written here, get the MRC score, symptoms, that means symptoms, is on the x-axis, the horizontal axis. On the y is the previous history of exacerbation, present or not. So if there is minimum symptoms as depicted by the MRC scale of 0 to 1, they are in this side, horizontal. So this is the center, so we come either in B or A, we come over to the A side. Now we ask about the exacerbation history. If there is no exacerbation history at all, or there's only one, which is not leading to hospital admission, I beg your pardon. So it will be here, not in the A or C. So it will be here in the A part, okay? So which is the lowest. Or you see the other way around. If there are more symptoms, you go, yeah. So now symptoms are on which axis? Horizontal axis. So if there are more symptoms, patient is having more symptoms, or MRC scale of 2 and above, he comes into A or B, it comes into the B side. Then we ask questions on the y-axis. What is those questions? Exacerbation history, present of more than 2 or not, or only one, but what leads to hospital. Not every exacerbation leads to hospital admission, which can be done as an out. So that is the thing here. So if it's more, so it comes over the highest category, the D, the more severe category. Okay, this is how we do it. A, B, C, D of the COPD. Differential diagnosis is very important when in making the diagnosis of COPD. Asthma is the main contender. See, asthma, the differentiating few points, asthma is generally is onset early in the life, often in the childhood. The symptoms vary. There's a diurnal variation, same day, within day and night, diurnal, we call it. More worse in the early morning hours. Why? Because there is a physiological dipping, normally present of the at the early morning hours, and there's exaggeration of this thing in asthmatics. Plus, there are symptoms vary widely from day to day. Some days are very good. I mean, they have completely symptom-free. Some may be vague as well. So that is how it is. So, but in the COPD, generally, some kind of dyspnea is always present. But asthma may have a complete normal without having any symptoms at all between the attacks. And plus, there is a family history of asthma present, and in may start from the childhood, may start adult as well, but generally it is. Congestive heart failure is another thing we have to differentiate from the COPD, but that can be done easily by clinical signs of displaced apex beat, raised JVP, there are murmur present, if present, functional MR, functional TR murmur, or you do a X-ray, there's a dilated heart, and you do an echocardiogram, which is showing the low ejection fraction. So there are a lot of reasons which we can easily differentiate. Bronchiectasis is the permanent dilatation of the airways, smaller airways in general. There will be a history of large volumes of sputum production. Tuberculosis can be differentiated very easily. The rest are very rare diseases. Vaccination prevention is better than cure. Yes, it is recommended in COPD to vaccinate them, and there are two vaccines available generally is we use here is the one is the 23-valent pneumococcal vaccine, another is the 13-valent conjugated pneumococcal vaccine. This slide is busy, but it's just not to tell you everything, just to tell you the group spells basically. Yeah, so we use there are certain bronchodilators. The main hallmark of COPD management, if you come to, is the inhalers or bronchodilators, and bronchodilators in the form of inhalers. So one is the short-acting beta-2 agonist, then we have long-acting beta-2 agonist, the LABA, we have anticholinergics, which can be short and long, both. So like both have short and long, then you can combine these two together as well. That means short-acting beta-2 agonist with the anticholinergic in one device as well. Or you can combine the long-acting beta-2 agonist LABA with LAMA, which is a long-acting anticholinergic. Corticosteroids, which can also be added. So we have from dual combination of bronchial dilation to triple, so adding steroids as well. Then another things we can use are the methylxanthines, previously very relatively cheaper than the inhalers, but they are less effective and having more side effects. Theophylline, aminophylline, so generally we don't use it commonly, but we can use them when people cannot afford. We can use them in a small dose. Phospho, you can do the phosphodiesterase 4 inhibitors. Roflumilast has got a very specific indication, otherwise generally it's not used. The mucolytic agents are also sometimes used. Carbocysteine is one of them. The basic thing you need to stress are the inhaled route. All the medicine of the COPD should be on the inhaled route, not oral route. Okay. There are some other pharmacological treatments when the COPD is due to alpha-1 antitrypsin therapy. You can use the deficiency of that enzyme as an augmentation therapy. Antitussives generally have no role, and vasodilators also have no role. Pulmonary rehabilitation is one of the integral part of the COPD of the advanced level, C and D in particular. We classified A, B, C, D, remember? So in the advanced loop, in the advanced people having advanced COPD, this is recommended. Oxygen therapy is also for the person meeting the criteria for that thing, and that includes basically, we discussed what is the point. The long-term administration of oxygen that increases survival in patients with severe chronic resting arterial hypoxemia. So that has a very good evidence, which is A. So in patients with stable COPD and moderate, prescription of long-term does not lengthen time to death of first thing, but it increases the benefit in it has the benefit in the functional form, right? So I'll just give you this criteria. We went to initiate patients in the long term, we call it LTOT, long-term oxygen therapy to COPD patients. When we do the ABGs, in ABGs we check for what? PaO2. PaO2, yeah. Partial pressure of arterial oxygen, if it's less than 55, this is one of the criteria for initiating long-term oxygen. Or there is the PO2. PO2 is between 55 and 60s, more than 55 but less than 60. Plus there are signs of right heart failure, which are raised JVP, peripheral edema, hepatic congestion. Okay, on an echo there is dilatation of the right heart, so like this. Or there is no heart failure, but there is erythrocytosis or polycythemia present. Along with this thing, even then there is indication to give them oxygen. And the oxygen is given to keep the SA2. This is from the ABGs. The saturation of the arterial oxygen, that should be 90 and above. That is the target. When you keep them on the, put them on the LTOT, you reassess them in 60 to 90 days to see whether they still need the oxygen or not. By how? By repeating the ABGs, for example. There are certain interventional therapy in stable COPD patients. I just wanted to name, no details. Lung volume reduction surgery, bullectomy. Bulla is the presence of air pocket in COPD patients. Larger bulla in emphysema, some air pockets are larger and we call them bulla. There's certain cutoffs as well. So you're removing the bulla is bullectomy. Then you go for transplantation, or there are certain newer bronchoscopic interventions like putting the valves inside the disease segment. So that thing, the air is absorbed and that emphysema part is reduced. Or you put a lung coil, or you do the vapor ablation. They are very advanced procedures present only in very selected centers in the world. So management, just show you the diagram how to go. You first make the diagnosis on symptoms, risk factors and spirometry. Go for initial assessment. This we have discussed how you do the spirometry. FEV1, is it gold stage 1 to 4? We have discussed this. You check the symptoms, CAT or MRC scale. This is also checked, and take the exacerbation history. So two things, symptoms and exacerbation history. In this way, you will be able to classify at A, B, C, and D, which is the gold classification. You check the smoking status, you check the alpha-1 antitrypsin levels present or not, low or not, I beg your pardon, and the comorbidities. Then you start the initial management. The first thing is prevention. Prevention, if the person is smoking, ask him or her to quit smoking. And how to do, there's a separate talk on it. Vaccination, you go for lifestyle changes, you start with the initial pharma management, and then you review them. Okay, what's going on? That's how the general picture is. So what are the goals? We have discussed that there are certain goals of treatment. What goals? Two goals. First goal, reduce the symptoms. Second goal, reduce the risk. Risk of what? Risk of exacerbation. Right? So how to reduce symptoms? Relieve the symptoms. Improve the exercise tolerance. Improve the health status. In this way, you will be able to reduce the symptoms and prevent the disease progression, prevent and treat the exacerbation, and reduce the mortality. In this way, you will be able to reduce the risk. So bronchodilation is the key aspect. The key points for the use of bronchodilators are LABA, long-acting beta-2 agonist, for example, is indacaterol, for example, is formoterol, right? So these are those. LAMA is, for example, tiotropium, glycopyridium. They are preferred over the short-acting ones. The LABA long-actings, remember, are preferred over the short-acting. Short-acting, salbutamol. Short-acting, ipratropium. So don't use the short only for certain, this written, but generally they are preferred. So this is the general rule. This slide is telling what to give what, in which group. So 4 groups, remember, A, B, C, and D. A is the mildest one, and D is the severe, isn't it? So mild is simply, you can start with the bronchodilator, right? And you go to the group B, you add LABA, long-acting one, or the LAMA, the long anti-muscarinic one. In C, generally LAMA. So here you also starting yours depending, but generally is combining the LAMA with LABA. And at times we also add the steroids. See, here is the big management difference with asthma. In asthma, we also use inhalers. We also use short-acting. We also use long-acting ones. In the LAMA, LABA, But the difference in general is in COPD, we start without starting with steroids. Steroids are added late in the diagnosis, in the management, in the more severe ones, or there is an eosinophilia present. The classical, there are criteria for that. But in asthma, you start with the inhaled corticosteroid. So there is a difference. Okay. Exacerbations, we have just talked a little bit about exacerbations. Exacerbations, when somebody had a COPD exacerbation, when there is a worsening of the symptoms and the exacerbation, which leading to the change in the management. This is the COPD exacerbation. So you have to rule out whether the person is having pneumonia. If person is having pneumonia, go for chest X-ray. Main thing. If there is decreased breath sound with hyperresonant percussion note, and you a dark X-ray on one side and other side is white, you suspect there is no bronchovascular markings beyond a certain clear-cut line. We think of a pneumothorax, for example. You go for a chest X-ray. Go for pleural fusion. You see the white-out lung with the meniscal sign present, blunting of the costophrenic angle. You start suspecting pleural fusion, for example. Pulmonary embolism, you do for T-dimer, or you do the DVT Doppler for lower extremities, or in the hallmark is to do the CTPA, the CT pulmonary angiogram done by the CT. So pulmonary edema, do the echo, cardiac enzyme, arrhythmia, do the ECG, for example. The other differential diagnosis for COPD exacerbation. Manage the increasing dose, give them steroids. If he is able to take orally, give them oral. If not, give them IV, give them antibiotics if there's infection, or very important component, to give them non-invasive ventilation when required. We'll just discuss in a minute, very briefly. In the meantime, you keep the fluid balance and give them DVT prophylaxis, and you treat the underlying any associated condition which is there, like heart failure, arrhythmia, or embolism, etc. So when to go for NIV, that is non-invasive mechanical ventilation, also known as commonly BiPAP. So at least, which is the trademark, not the of the machine. So at least one of the, when there is respiratory acidosis present, or when there is severe dyspnea with signs of muscle fatigue, and there is persistent hypoxemia, then you can consider if the ABGs is less than 7.35 with PCO2 of more than 45, along with all of this, or maybe one of them, you can start suspect going for NIV. Mechanical ventilation, invasive, previously which I discussed was non-invasive, NIV. Now I'm talking of the invasive one. We call it commonly as putting them on ventilator, for example. Tracheal intubation I'm talking about, and putting them on invasive ventilation. So in the person who are unable to tolerate NIV, or they are having after a cardiac arrest, so don't put them on NIV. This is indication to put them on invasive mechanical, or they're too drowsy. We can't apply the NIV BiPAP, or there's a risk of person has got a massive aspiration or persisting vomiting. Don't put them on invasive ventilation, like this life-threatening arrhythmias, ventricular, with that means hemodynamic instability. These are all factors which put them likely to. A few slides, but very important one of them is the respiratory failure. See, the definition of respiratory failure we'll just discuss and then break down in different parts in order to know what it is. So the definition is the inability of the respiratory system to meet, number one, oxygenation, ventilation, or the metabolic requirements of the patient. So this is, so let's break this definition down. The first is respiratory system in the green here, taken from here. The respiratory system, the lungs are the major players, but remember, upper airway, chest wall, cardiovascular, neurology, they are all very important. Chest wall deformity, for example, kyphoscoliosis, or there is a severe heart failure, or a person is having stroke, or phrenic nerve paralysis, so can't have the diaphragm innervation. They all are very important. So they can cause requirements. Type 1 respiratory failure. What is type 1? Is defined when the PaO2, the partial pressure of arterial oxygen, is less than 60 millimeters of mercury. This is the definition. Only. The first priority is always to correct hypoxemia, because hypoxemia can kill. Okay? Ventilation requirement. This is the part of the definition. Ventilation, acute type 2 respiratory failure, for example, when the PaCO2, the partial pressure of carbon dioxide, is more than 45 millimeters of mercury with a pH less than 7.30. This is for acute one, because we can have chronic as well. So that's why it is mentioned here. So in type 2, remember the concept is, in type 2, person is having the less than PO2 of 60 is must. But in addition to that, of low partial pressure of oxygen, the carbon dioxide level is high. This is in type 2. Whereas in type 1, there is only oxygen level of the arterial oxygen level, PaO2 is less than 60. In this, apart from this, the PCO2 is also high. pH is important in differentiating from acute from chronic respiratory failure. The third component of the definition I mentioned was metabolic requirements. This is often forgotten. Why? Because lungs have a key role in maintaining metabolic homeostasis. Carbon dioxide clearance is adjusted to balance out metabolic derangements. Oxygen intake and delivery to the tissues begins in the lungs. Now, the last part of the definition was of the patient, and that is the most important part. Why? Because a particular patient may have normal blood gas numbers, but still require respiratory support. For one reason, numbers, but may not require any kind of acute intervention. So what to do? Start with the history and examination. So don't treat the labs, treat the patient. So coming back to this thing, the diagnosis of respiratory failure is based on ABGs. You cannot diagnose on clinically. So symptoms and signs are fairly non-specific. So the diagnosis requires an ABG. So based on this thing, type 1 is when the PO2 is less than 60 only, and type 2 when the PO2 is less than 60, but PCO2 is more than 45. Then the classification, based on this, you can classify as acute respiratory failure, chronic respiratory failure, and the mixture of these two. A person is already known case of chronic respiratory failure and now acutely deteriorated. So we call it the last category, the third one, acute on chronic respiratory failure. In order to understand the concept, you need to see here that the respiratory system consists of two parts. One is the lung part, the other is the pump part. The lung part is responsible for gas exchange. The pump part, which comprises the chest wall, respiratory muscles, diaphragm, right, innervation, everything, that is responsible for ventilation. So gas exchange reason is to supply oxygen to the blood. Ventilation means, in general, eliminate the carbon dioxide from the blood. The two different concepts. So lungs, when fail to provide adequate oxygen to the mixed venous blood, this is the type 1 respiratory failure, also known as hypoxemic respiratory failure. But when the pump, see, initially I talked lungs, now talking pump. When the pump fails to eliminate, this is type 2 respiratory failure, which is the ventilatory failure. What are the mechanisms of type 1 or hypoxemic respiratory failure? There are 7 mentioned. Shunt. We don't go into the detail because that's all must be covered in the physiology. Shunt, VQ mismatch, diffusion limitation, dead space, low FiO2, low barometric pressure, alveolar hypoventilation. So in general, but few of them you can exclude very quickly, all of this. How? If you see, low FiO2 is generally when you are at high altitude, for example, and high altitude. So if you are not at a mountain or something, or very high altitude area. So this is generally excluded for a person. And low barometric pressure is generally when there is one can have it so for certain reasons. So if they're not there, like there's a house fire, so you can have the low fraction of inspired oxygen there as well. So that can be excluded. Thank you very much.
हेलो सर।
जी कंप्लीट हो गया जी।
जी सर, तो क्यूए करना है सर?
मर्जी है, कर लें। जी जी।
So the students, you can ask question on the chat box and also raise the hand, so I will unmute your mic.
अब मैं क्या करूं, ये एस्केप करूं ये प्रेजेंटेशन को या
जी सर, आप एस्केप कर दो या कुछ भी।
एस्केप करा मैंने, और अब वो खोल दीजिए आपका वो जो है क्या कहते हैं विंडो।
जी जी
वो
सर।
कैसे खुलेगी? वो नहीं खुल रही मेरी तो जी। I can't hear. Excuse me. सर वो लेक्चर हो गया, वो क्यों नहीं शायद होने वाली, वो विंडो नहीं खुल
सर इनको
जी विंडो शायद खोल दो, क्या मेरी तस्वीर या उसकी पता चल जाएगा। नहीं माउस तो ये चलेगा ना।
हेलो सर।
हेलो
सर
जी, विंडो खोल जी। हाँ चैट खोल दें। चैट क्या कह रहे हैं?
लेक्चर खत्म हो गया।
हाँ लेक्चर खत्म हो गया,
तो बड़ा कर लें
फिर क्या करूँ मैं?
ये आनी चैट सर जवाब देते हैं आप लोग पूछ रहे हैं।
ABCD चार्ट प्लीज। यस सर।
ABCD चार्ट को दोबारा दिखा दें?
जी जी जी।
ओके मैं फिर अब मैं कैसे, एक्सक्यूज मी, प्रेजेंटेशन दोबारा मैं दिखा दूं। मैं आई एम जस्ट डूइंग इट। जरा खोलिए प्रेजेंटेशन मेरी चल रही है ना, वो जरा खोल ली यही वाली इसको। तो आई विल एक्सप्लेन इट अगेन। ओके ये मैं बता रहा हूँ आपको, बता। अच्छा उसको ऊपर कैसे जाएगा वो? ये ABCD जस्ट अ मिनट। ये हियर इज द, इसको बड़ा कैसे करूँ मैं? इसको यहाँ करूँ, ये कैसे हटेगा? मिनिमाइज कर। Here is the ABCD. See, ABCD, in order to understand the ABCD, you understand two things. There are two things. On the x-axis, there are symptoms. On the y-axis, there is an exacerbation history. They are divided, for the example, the symptoms are divided. Either the patient on horizontal will be in the A or the B, isn't it? Based on symptoms alone. Forget this, the vertical axis. Just concentrate on this thing, the horizontal, A or B, isn't it? Horizontally, okay? Or C or D, right? But A or B. So if there is MRC scale, the symptoms are less. Based on this assessment, symptoms are less. Patient will be in B or A? Patient will be in A, because symptoms are less. Okay. If the symptoms are more, based on MRC scale 2 and above, okay, forget this, because we have just tell you how to do this. But if the symptoms are more, patient will be in the B side. Now we ask the second question. What is that? Exacerbation history, which is the y-axis. In the exacerbation history, if the person is having no exacerbation, that is 0, or person is having 1 only, and even that 1 does not lead to hospital admission, that means it is in the lower category, is less severe, right? So less severe is A or C. A, not C, okay, because C is with the higher one. It is associated here with 1 hospital admission or no hospital admission, simple clinic visits of 2 or more with exacerbation. So that leads to C. So in this way, you ask 2 things and you categorize the patient, whether the patient is in the A, B, C or D. So if a person is having low symptoms, it's in the A side, this side, from the 50%, this side. Now I ask, What is the exacerbation XT? He says he is more than 4 exacerbations. Okay, so he is in C. So patient is in the C, the highest category here, C. If the patient is having low symptoms and no exacerbation, so he will be in A, and exacerbation low, so A also, the both sides is A. Okay. If the patient is having more symptoms, is in the B, and no exacerbation is remains in the B, but if it has exacerbation more than 2 or 1 leading to hospital, it goes into the D1. This is how we classify. Hope answered the question. Hello. Hello.
Yes, sir.
Ji, okay. Thank you.
Yes. Sir, can you see the?
और कोई questions तो नहीं?
Yes, sir.
नहीं, I
Can you
can't.
see your
I
chat
can't
box?
see chat box. Chat box को एक second. It's not there.
सर मैं बताता हूँ
बता दें. Chat box खोल रहे हैं, वो आ गए हैं help के लिए. Chat box क्या?
इनको कहे सर मोड में जाके नीचे डाउन.
मोड ये कह रहे हैं मोड में जाके. मोड
डाउन.
मोड या मोड आ गया.
मोड MORE.
मोड
ये लगाया ना आप जी ने आपकी जैसे
जी.
क्लास डिस्टर्ब हो रही है भाई.
अच्छा सॉरी सर.
जी भाई जी आगे. ओके.
यस सर, इसमें आप रीड करके क्वेरी कर सकते हैं.
कोई है तो बता दें क्या क्वेरी. वो एक तो मैंने बता दी, और कोई क्वेरी है तो मुझे बता दें.
सर प्लीज समरीज MMRC एंड कैट स्केल.
CAT scan, देखिए CAT scoring is not supposed to just try to mention it. This is mentioned on the gold guidelines. You need not to memorize it. So it's not. It just mentioned how to calculate it. Is a scoring present online calculators and this thing? Not. We are not concerned. We just start to mention it for the assessment. So need not to bother about the details of CAT score and the MRC. MRC is very simple score, but CAT score you need not to memorize it. Anything else?
Please explain how we differentiate COPD with other conditions.
Well, I have just mentioned it earlier. Okay, in different conditions like asthma, for example, you need to differentiate. Asthma is generally early onset. It is the family history positive. In asthma, there is a diurnal variation. There is a seasonal variation. There is history of atopy, for example. All things are not present in COPD. Plus, COPD is generally starting at the age of 40 and above in general. One can have an early age COPD, for example, with alpha-1 antitrypsin deficiency, but it's not common. So, and as far as the another condition, for example, heart failure, some people call it cardiac asthma, previously used to be called. CCF or congestive heart failure is a different entity. A person with the history is different. There's orthopnea history, there's a PND history, there's orthopnea, PND, plus there is a raised JVP on examination, there's a displaced epic speed. Then you do an X-ray, there's a big heart on X-ray, cardiomegaly, and may have bilateral perfusion or may not have. And you do the finally echo, the echocardiogram showing the low ejection fraction and dilated chambers of the heart. So this is generally differentiated in this fashion.
Sir, why there is anemia and osteoporosis in COPD?
Yeah, anemia is generally for any chronic disease. It's a disease, anemia of chronic disease in COPD in general. So any chronic condition, COPD is a chronic condition, can have the anemia for that reason. Osteoporosis is a very complex system. Why? Because the person is having disuse, low mobility because of shortness of breath, and with over a period of time, there are certain other reasons as well, which lead to the general debility over the period of time, and that leads to the osteoporosis and anemia as well in general. Yes. Why there is a paradoxical chest? Yes, that happens because this we call it in order to understand the inspiration is an active process. If you recall from physiology, and expiration is a passive process. So, and there is a bucket and handle analogy in defining the chest wall. Thing in the chest wall mechanism is it's just like a bucket and handle, because the ribs are at a certain angle. When there is a hyperinflation, and that leads to barrel-shaped chest, the ribs are at a mechanical disadvantage. And what happens? The respiratory muscles become more horizontal. The ribs become more horizontal. And when the person inspires, so the diaphragm also become flat. So that leads to the indrawing of the muscles of.
Okay, sir. The time
Yes,
is over.
very
So
okay. Thank you very
so
much.
can we end it now? Thank you, sir. Thank you so much.
Thank you very much. Thank you.